welcome back to the online DC&R Journal Club, our first session for the year. From the spiritual home of colorectal surgery here in Melbourne, happy Australia Day. We have a national holiday. Now, we are very excited to welcome all our viewers and look forward to a great 2021, where we will undoubtedly dominate the booming colorectal journal club scene. Our goal this year is to consolidate what we've started, expand our audience base, and to start including some international speakers. Next slide, please. So I'd like to thank the journal club team, which is very well led by our DCR editor, Dr. Galendiak. Next slide, please. This is our disclaimer, which is pretty self-explanatory. Next slide, please. So I always get excited about Journal Club, but I have to say this is the first time that my children were more excited than I was, be it briefly. Orlando seems like an amazing place, the home of both Disney and Universal resorts, and it's on the bucket list for my family. However, it is somewhat concerning that the most recognizable photo of the not so magic basketball team is 20 years old. Next slide, please. So we're very grateful for the colorectal department from Advent Health to host us today. It is a very respected, innovative academic surgical unit with a highly sought after fellowship program. Next slide, please. I'm particularly indebted to Dr. Garcia Henrique and Dr. Monson for reaching out and coordinating this as a host institution. And I would be grateful if Dr. Monson would introduce the panel. He himself is, of course, a co-editor of DC&R, executive director for colorectal surgery at Advent Health, and has extensive clinical and academic experience both in the UK and, of course, in the US. So, Dr. Monson, please.
Yeah, good evening, everyone. Thank you, Vlad, for that. And I'm sorry that the Orlando Magic are just working up towards resolving a few team selection issues that we'll soon have sorted out before too long. At least that's what we are planning. So, yeah, I hope we have some interesting things to talk about today. Again, as you, I'm grateful to Norbert Garcia Enriquez for taking the lead on this for the group. And his partner in crime there, as you can see on the screen, is Jesse Wright, who is one of our faculty. Also, hopefully able to contribute this evening is Matt Albert, who is known to many people, and the founding father, if you like, of this group some years ago. We have two of our current fellows taking part this evening in discussing a couple of the papers, Alex Salas and Megan Daly. Hopefully I'll be able to stay out of the crossfire for most of the evening until you start grilling me about whatever you want to talk to me about in terms of both sides of the Atlantic. So I'll hand back over to you, Vlad.
Thank you. Next slide, please. So we have a poll. We've got two polls today, and Stephen Brandstetter is in charge of those.
I'm going to bring it up while you're talking. So we're going to start off with this first poll. I'm trying to gauge this against some responses later in the program. For a patient that you're seeing that needs an ultra-low anterior resection, and you think that you can consider a reconstruction, which operation would you choose if you were the patient? So, we're going to give it 2 minutes, and then I'll close this down. So then we'll look at the results in a little while.
Fantastic. So whilst it's running in the background, let's move on to the next slide, please. And so I will, sorry, I don't know if it's just my screen or not. There seems to be oh yeah, perfect. Terrific. So I'll give the microphone to Dr. Elias first to start presenting on this first paper. Thank you.
I'm Alex Elias. Thank you for giving me the opportunity to talk to you all today. I'll be presenting oncologic and perioperative outcomes of laparoscopic open and robotic approaches for rectal cancer resection, a multi-center propensity score-weighted cohort study. The background and aim of this study was that for other malignancies, it has been demonstrated that minimally invasive approaches have an ability to reduce surgical site complications without compromising oncologic outcomes. Yet for rectal cancer, there have been contradictory results. The primary aim of the study was to compare rates of successful oncologic resection among laparoscopic open and robotic approaches, with the secondary aim being to also compare postoperative outcomes, including systemic and surgical site complications, readmission, reoperation, operative time, and length of stay. Next. This was a cohort study utilizing 2016 NISQIP data. They used boosted regression models with 19 preoperative variables and analyzed those with propensity score-weighted logistic and linear regression models. The patients they included ranged in age from 18 to 89 years, and they had to undergo rectal cancer resection via laparoscopic, robotic, or open technique. If it was open assisted, this was excluded. It was also excluded if they had to convert to open. The outcome variables measured included successful oncologic resection, which was defined as a negative distal radial margin with more than 12, or excuse me, at least 12 lymph nodes evaluated. Surgical site complications, which was defined to include bleeding requiring transfusion, leak, wound dehiscence, and surgical site infection. And systemic complications, including ileus, pneumonia, reintubation or prolonged intubation, PE, DVT, progressive renal failure, UTI, stroke with neurologic deficit, cardiac arrest, MI, septic shock, and sepsis. The primary results revealed that both open and robotic approaches had a lower likelihood of successful oncologic resection, with rates of 69 and 68% as compared to 77.7%. It also showed that open operations had a lower likelihood of a negative radial margin on multivariable analysis, looking for the main component contributing to this. In addition, open surgery was more likely to have surgical site complications as compared to a laparoscopic approach, and a robotic approach was more likely to require readmission. While one of the things that people criticize about robotic approaches is the longer operative time, this study actually demonstrated that there was no difference in mean operative time. The authors concluded that the laparoscopic approach is more likely to achieve oncologic success with fewer surgical site infections, and that minimally invasive approaches are associated with a reduced length of stay without an increased operative time. However, they noted that they had many limitations, including those regarding the NISQIP database, which is subject to human error because of the way it's reported, as well as data not being available on hospital-specific and surgeon-specific volume. Unobserved covariates such as surgeon experience and case complexity, which would obviously contribute a source of bias. Higher rate of colostomy than you would anticipate in the real world. It was at 54%. And then the inability to account for completeness of TME in addition to selection bias.
So I have a couple of questions for you, Alex. I think that was a nice, very succinct job of presenting this article. My first question to you is, what are your thoughts when you look at how they designed the study on the distribution of the patients that underwent robotic versus laparoscopic versus open? And how does that potentially skew the results that were noted in the study?
So there were about 3 times as many open patients as there were laparoscopic patients or robotic patients, which means that I think it's harder to interpret your numbers. It could potentially lead to open weeding out some of the bad data, if you will. And additionally, you have to question whether there was a selection bias in that more complicated cases were done in an open fashion.
Yeah, and so that's right. The issue that I see is that when you look at this paper, the patients that were approached from an open modality, it seems to me that the patient's pathology and disease process was much more complex, much more advanced, as opposed to the patients that underwent robotic and laparoscopic surgery. And so that certainly will influence your results, in my estimation. So the other question I have is, you're going to be a practicing surgeon, colorectal surgeon soon. And so if you do have a patient with a rectal cancer, what are you going to tell your patient? The patient has already undergone the treatment that they're going to need, and now it's time for, you've made a decision that the patient is now an acceptable candidate for surgery. So what would you tell your patient, and what would you base that discussion on?
So I feel very fortunate training here at Advent Health because I'm able to learn all techniques from my attending physicians. And so I'm going to base it on a case-by-case basis. Ideally, I would approach it in a minimally invasive fashion. However, I think that I have to take into consideration patient factors, patient history, patient preference, and really be frank with the patient about what the risks and benefits of each approach are.
Yeah, because I think, and I totally agree with you. I think, and I'd be curious to see what some of the more wiser people on the call would have to say. But, when you look at a rectal cancer case, I think it's all about what you're comfortable doing and how the patient is going to do in your hands. For example, for me, yes, I know in our practice, we'd like to do everything minimally invasive, as do I. But I feel more comfortable when the time comes to the proctectomy. I was taught to do it open. And when you look at studies that have looked at this carefully, such as the a la carte trial, the Color2 trial, and even Dr. Fleshman's paper, the ACOZOG Z6051 trial, yes, these are non-inferiority trials, but there was a tendency to believe, based on the data, that perhaps from a short-term perspective, I do think that there is an enormous benefit to both robotic and laparoscopic surgery. But the reality is, what is the benefit long-term? Meaning, what is the oncologic outcome of these patients when you look at these modalities? And I think that all that to this day may, and I say that with a grain, very, very carefully, because I know there's a lot of eyes watching me, but I think that may favor open surgery.
I think that's a fantastic comment to throw out there.
Can I ask, as a dinosaur among you all, what do you do? I come from a state where, and I'm sure the same is true in Florida, where obesity is on the rise, and it's very common for us to see patients with BMIs above 45 coming with rectal cancers to you in Florida. How would you preferentially approach these patients?
Well, I think, at least for me personally, Dr. Galandiak, I'm still, and I think I will forever be a student of this profession. I am blessed to have people in my corner like Dr. Matt Albert and Dr. Monson, where, we could approach this sort of in a combined way. We discuss all our rectal cancer cases up front, as you would imagine. But we discussed it amongst ourselves as well. And when you do have a patient such as the one you're describing, certainly I would at least me, I would bump it off some of the more senior guys to get their perspective. And a lot of times what ultimately ends up happening is there's a combined approach, whether it's an abdominal, laparoscopic, open, but then there's also a transanal approach, and we sort of rendezvous together. And I think we've had success in our practice this way. But yes, your point is very well taken. I think for the most part, the state of Florida is getting a bit chunky and chunkier. So you're absolutely right. And these conundrums come up, unfortunately, way too often. But yes, I think we approach it as a group, and I do bounce it off those wiser guys than I.
And I would comment, Susan, first of all, I would comment, Norbert, that both Susan and I fully understand that when you say wise, you mean old. I think we both recognize that at that moment. But the reality is that, I would point people back to the ASCRS meeting in LA when the 6051 study was presented. And a panel was held of the PIs of the 5 randomized trials that were done on minimally invasive surgery, as you described. And I remember this because I was asked to present something at the end of it, which was called Making Sense of It All. And what interested me was that of the 5 PIs, 4 of them had chosen in their current practice to essentially ignore the results of their own study and continued to do minimally invasive approaches for the majority of their patients. We all know that there are patients out there where it's simply impossible to do something laparoscopically, robotically, or whatever it might be. And that was my summary of that experience, was that rectal cancer is a difficult condition to treat. And that's really what 6051 said, that there are some occasions when a laparoscopic approach cannot deal with every aspect of it. And we should be willing and able and trained to bring whatever we have to the table for each and every patient on a case-by-case basis, as you've indicated.
I see we have some of our other editorial board members attending here. I see Dr. Keller, I think Dr. Colon, and Dr. Ficara on. I don't know if any of them would want to comment.
I know to unmute at this point, sorry. I think Dr. Ficara and I have the same initial issue of the database used for this. This is not the right database for a cancer study. And I think that when we start to talk about rectal cancer outcomes based on NSQIP, where they really just don't have the oncologic outcomes, it's almost dangerous. They excluded cases that were converted instead of using intention to treat. And I think that that's another problem. I think that the patients could have been matched better based on their preoperative demographic variables. But again, those are also limited in what we have for NSQIP, and they're more perioperative enhanced recovery outcomes and quality outcomes. But, I remember the talk that Dr. Monson discussed at ASCARS. And when Dr. Fleshman was asked if he could pick what procedure his wife would have, despite being the main author on that paper, he said he would do a laparoscopic resection on her. So we have to look at the endpoints that were chosen as well, and the surgeon's skill. And that's something that wasn't really considered.
Yeah, on the other hand, if I may, this is a real life, I disagree with the statement, this is not real life. 54% colostomy rate, as John knows very well from Ostrich, it is real life. So this is real life data from surgeons that are not particularly trained or necessarily trained in minimally invasive or robotic, and they do these procedures open. Granted, it's hard to extrapolate clean data from a real life experience, but I think this is as close as it gets to what we see coming from East Texas, from West Texas, from the rural North Carolina, and so on and so forth. So it's I think has value. This paper has value as a snapshot, like Ostrich did when they looked at the rate of APR in the country. a snapshot of the rectal cancer environment in the U.S.
I have a few questions to the panel. The first question is, in this paper, oncological success was defined as negative distal margin, negative radial margin, and greater than 12 lymph nodes harvested. Are there any scenarios where a positive distal margin could not be prevented? Maybe Dr. Garcia.
Well, I think in one of those, the only scenario really that I can think of is when you have a very, very low tumor. But then you're talking about an operation that you're not going to restore intestinal continuity. So I think in that sense, that would be a scenario where you potentially have performed a resection and there's a positive margin. But do I think it's acceptable? No, I don't think it's acceptable. But that would be the only reason where I think, you would have that scenario where, you'd have a very, very low lying tumor, but I don't think under those circumstances would you offer anyone even an ultra low anterior resection. I think those patients inevitably end up having an abdominal perineal excision.
So is it just a matter of not opening the specimen at the time of dissection afterwards to check? I remember when I was Dr. Steele's associate, I did what I thought was an excellent case. I was high-fiving everyone in the theater, in the OR, and then in the end, he came in and he said, "So did you check the specimen?" And we opened the specimen and it had a positive distal margin. So we did convert to an APR. And I think the patient did fine. But that for me sort of has been ingrained into my memory as not really it's a different kind of indicator.
Yeah, no question. I agree with you, Vlad. I think, and I'd be interested to see what some of the other faculty have to say. But I think the other thing too in this paper, to Dr. Keller's point, where they did not really look at critical pieces of information that you would get from a cancer database, for example, that you miss out on the NSQIP data is, so they looked at these criteria as a surgical appropriate oncologic resection where you had a radial margin and your distal margin that was negative. And then you also had a lymph node harvest that was above 12. But what about your TME grade? That's not something that I don't think was discussed. And I think, the better your TME grade is, I think interprets long-term as a predictor of good outcomes, specifically when it comes to local recurrence. And so that's another big thing that I think was not looked at carefully in this study.
Thank you. The other point with the oncological success that I found interesting, and one of the other studies this month that we featured was from a team in Brazil led by the first author is Dr. Andre Dias from Sao Paulo, that talked about using carnoise solution compared to formalin as a fixative and demonstrated that they got a increased lymph node count. And so that makes me wonder if we use the 12 lymph node status as a measure of quality, and all of a sudden that is not an objective number, given that some pathologists can get more numbers, more lymph nodes than others, is it something that should be part of a synoptic pathological report where everyone uses, say, carnoise solution or not, so that, it's a level playing field?
Yeah, I mean, that's a great point.
If any on the call with a MD, with a tumor board where they integrate some sort of pathological discussion on, how the lymph nodes were harvested.
Yeah, I think in our practice, Dr. Monson is continuously preaching standardization and how best to optimize the approach to all the facets of rectal cancer, but clearly that is one facet that I think would be very, very interesting to look at, because I do think, and again, I'm curious to see what the other institutions think about how their pathologic process is. But I think in my brief experience in this process is I think that the pathologist sometimes tends to not be as astute in looking for the appropriate amount of lymph nodes. You know, the reality is we look for 12 because that's the standard, but, you know, why not look for as many as you can properly and, you know, more appropriately stage a patient, which ultimately would influence what their treatment is going to be and their outcome as well. But yes, I do think that using standard ways of extracting and looking for these lymph nodes would be yet another way of standardizing the way we approach rectal cancer in general.
Okay, well, thank you very much for that. Thank you for a couple of the points from the audience on the chat. I think we've addressed a few of them. Now, in relation to the TME, our next study will discuss that at length. So we'll continue that conversation there. But if there's no other comments for this paper, we may progress to the next. Sorry, Dr. Monson, I think.
Yeah, Vlad, I was just going to ask you what the modern Melbourne Vlad would say to the Cleveland Vlad about the case you described. What's the difference? What did you learn from that? What can we all learn from that? Because, you know, that's not unique to you, that experience.
I thought about that a lot, actually, and I think with the ultra-low rectal cancers, for me, sometimes it's an issue of transection as opposed to an issue of dissection. And I feel I've been trained in laparoscopic surgery, so that is my preferred approach. And I feel that I can get very low in the majority of cases. Not to say that, you know, everyone has their limitations, but what I find difficult is doing a double stapled anastomosis on a sort of a obese male where I just can't get the stapler in. And I have had a few cases where I've had to convert purely to get a TA30 down there because I can't do it any other way. Now, I think one of the things that I think about now in the tumor board before I decide what to do with the patient is that transection. And I think that's probably the biggest thing that I've learned from that case, to really focus on that.
That's why they do hand sewing.
I'm sorry?
That's why they do hand sewn anastomoses.
That's a word from the wise there. You see that?
Wise. He said wise again, Dr. Glenn.
Sorry, couldn't resist.
All right. Thanks all. Now, I think the next is poll number 2. And interestingly, so I didn't realize that Dr. Fleshman also asked this type of question earlier. I thought this was a unique idea. But please, Stephen, if you can talk about the next question.
So I'm going to launch this poll. So I'm going to try to read this one more correctly than last time. So next we have a similar question. Now it's your partner. There was discussion about family members. It was a little too personal. We're going to just do our partner. Required an ultra low resection, and now you're deciding what operation you would recommend for the, you know, close but not direct family member. I'm going to do the same thing. I'll give this 2 minutes, and then I'll go ahead and close polling after that, and then we'll look at the results in a little bit.
Initially, I thought to pick a parent, but given that some people are wiser than others, I thought that deciding on what to do on a parent might have anesthetic implications. So we thought we'll go with partner. Okay, and so whilst that's in the background, if we can progress with the next paper, please. So next slide. And Dr. Daly, thank you very much for presenting this.
Great, thank you for the opportunity to present in this forum. I'll be discussing the article Carbon Dioxide Embolism Associated with Total Mesorectal Excision Surgery, a report from the international registries. Next slide, please. Carbon dioxide embolism is a rare but potentially lethal complication of minimally invasive abdominal and pelvic surgery. Transanal total mesorectal excision is undergoing increased adoption worldwide for rectal resection. It requires high flow carbon dioxide insufflation in a low volume operative field. It is important to understand this potential complication in order to minimize its clinical impact. Timely recognition and effective management are crucial. Limited data exists regarding the incidence, risk factors, and management of carbon dioxide embolus in transanal total mesorectal excision. The aim of this study was to identify trends and potential risk factors for carbon dioxide embolus specific to TME. Next slide, please. This was a retrospective review. Cases on the international TME registries from LORAC, which included 169 medical treatment units across 42 countries, and Ostrich, which includes 52 units across 4 countries, were analyzed. Registry collaborators were queried regarding incidence of carbon dioxide embolism. Characteristics and outcomes of the 25 identified cases were then analyzed. Next slide, please. 17 centers of 10 different nations reported experiencing carbon dioxide embolism. The incidence was 0.4%. Males accounted for 76% of patients, and the indication for surgery was cancer in 80% of these patients. 92% of patients were in the Trendelenburg position when the event occurred. And as seen on the slide, 68% of those were in 30 to 45 degree Trendelenburg versus 24% in 5 to 25 degree. All cases of carbon dioxide embolism events occurred during the transanal component, with 60% occurring during synchronous abdominal and transanal operating. A flexible transanal platform was used in all cases. The air seal device was utilized in 96% of these. The air seal system responds immediately to changes in pressure and provides continuous pressure sensing, stable pneumoperitoneum, and continuous smoke evacuation. Visible bleeding was present in 84% of these cases. Most had transanally predominant venous bleeding, with 1 case reporting abdominal bleeding from the inferior mesenteric artery. Periprosthetic venous bleeding was the most common culprit. Next slide. A reduction in end tidal CO2 greater than 30% was the initial feature in 88% of cases. This results from a reduction in pulmonary perfusion and increased alveolar dead space. 56% of patients had hemodynamic compromise. Transesophageal echocardiogram is the gold standard for diagnosis of a carbon dioxide embolism. However, it was not used for any of the cases. Furthermore, TEE is not routinely used, likely due to high cost and technical complexity. After the CO2 embolism was suspected, urgent intraoperative transthoracic echocardiogram was used in 32% of cases. In all of these cases, the echo identified gas bubbles in one of the chambers of the heart. In the majority of cases, 84%, the operation was continued after reestablishing hemodynamic stability. Conversion to open occurred in 28% of cases. There were no deaths in this group. 48% of patients experienced a postoperative complication, ranging from clavien-dindo classes 1 through 4. These included wound infections, pneumonia, urinary tract infections, pelvic collections, renal failure, and a pulmonary embolism. Next slide. In conclusion, carbon dioxide embolus is a rare but potentially catastrophic complication of TME. Surgeons and anesthesiologists must have a very high index of suspicion to limit its clinical impact. Identified risk factors include venous bleeding or wrong plane surgery, with particular attention to Batson's venous plexus around the prostate with its network of valveless veins. In women, the vaginal veins are the anatomic equivalent of these. High insufflation pressures in small operative spaces, as well as patient positioning, were identified as other risk factors. During other minimally invasive transanal techniques, such as transanal microsurgery, the colon remains open, which allows for easy diffusion of the carbon dioxide along it. However, in TME, especially during periods of prolonged suctioning, when you encounter bleeding, the air seal device automatically compensates for pressure loss by initiating a very high flow of carbon dioxide in order to prevent operative field collapse. Regarding patient positioning, Trendelenburg creates a pressure gradient that may promote carbon dioxide embolus in the venous system. This remains controversial, but recent evidence does suggest that the degree of elevation is directly related to the rate of carbon dioxide embolism. As a retrospective study relying on completion of a questionnaire that was sent to the parties, the study is susceptible to significant bias, including ascertainment, reporting, as well as recall bias. Given that CO2 embolus is such a rare event, this resulted in a small sample size for analysis in this study. The flow diagram to the right depicts the American Heart Association guidelines that all surgeons and anesthesiologists that are performing these surgeries should be very familiar with and able to act accordingly. Thank you.
Thank you for that. I think, Dr. Wright, do you have any comments?
Yeah. Thanks, Vlad. So, Megan, that was fantastic. I'm Jesse Wright. I'm one of the junior most members of the group here and train under these guys. And about half of the group does TME as part of their routine practice. So I hope to engage them in some of these points. But certainly, this is a touchy subject in the realm of TME. And I know this is with several different international moratoriums or pauses that exist. Trying to find adequate and accurate data supporting some of these facets is important. One of the first things that struck me with this paper in general was the actual pathophysiology of a CO2 embolization. It's not something that we as abdominal general surgeons see too often in routine practice. And for many of us, it's the really only experience we have is during central line placement during residency and kind of managing and triaging that. So to have this become a problem in the operating room during in increasingly important in dissection from the transanal side of things, I can see how this was catching people by surprise. So I wanted to actually touch, and Dr. Albert, I saw him if he's around, but he was one of the early pioneers in this. So I wanted to ask him about maybe his initial experiences with this phenomenon, what his initial response was, and kind of how it developed in his experience. But if he's not, then I could also, let's see if he's on. Dr. Debesh Adams was there as well, or anyone else who kind of first saw this and how they managed it when they first initially diagnosed it.
Well, thank you for officially unmuting me, and thanks, Vlad, for organizing this. And just to be clear, as you were insulting our rebounding magic, Advent Health, our unit just southwest of us, is also sponsored Advent Health and the Tampa Bay Buccaneers, Tom Brady. So setting records all the time. But thanks for having this article discussed. I think as at the tail end of the last discussion, what brought up was obese surgery. And in fact, at our institution doing this back in 2011, 2012, those who have, been to our courses have kind of heard part of the story, we preached and told, and that was our experience early on was based solely out of the necessity of massively morbidly obese patients with distal tumors, where we've all been there, I think, where it becomes not even a component of can I reconstruct this person, but can I get this thing out? And to this day, when people ask me about the perception on TME, the fact is that it remains, I think, a needed tool in people's armamentarium just for this exact same reason. As regards to the paper, I was also one of the authors. I was also one of the victims as a surgeon in doing this. And in fact, I was even one of the cases where the editorial commentary, looked at somewhat shaming about that these surgeons didn't carry on like experts in the face of this horrible problem. But that is, in fact, the exact point of this. There's lots of reasons people may publish papers, some from complete torture of their program director, of their boss, some for academic egos. But, this was done for only one reason, and that was to educate people. The fact is, I had done thousands of laparoscopic, robotic, in every orifice, in every which way, laparoscopy, and never have had a patient had a sudden cardiac arrest in front of 20 other visiting surgeons. And so this caught us off guard. And this was the similar experience as all these other institutions that this, I thought was very commendable that we were able to round up these single case reports that would have been otherwise in some back journal somewhere, and rounded them up to see that there was one more unique problem that we were faced with. And certainly it was just a combination of a new technique in this small space, using this highly evolving technology, high flow insufflators at higher pressures to maintain better and better visualization. And that combination provoked something that many of us had not experienced before. I can tell you that mine started out on a ski lift at the Alpine Colorectal meeting with Felix Eigner, a surgeon at Charité. And we said, boy, we both had one of these. We need to hurry up and write and publish this up, which then quickly discussed with Dr. Monson, who said, wait a second, there's got to be more of these. And we pulled a few fellow surgeons who we knew who were doing this, who said, yep, we have some too. And then we quickly spoke with Roel Hamps, as we were always part of the TME collaborative. And together we found this somewhat ominous finding, still a very small fraction of percent, but that leads me to a real change in practice now, in something that I've never done. And that the unique thing of all these cases is the gold standard test to diagnose them is hardly ever employed, because nobody carries a TEE around. And by the time the dust settles, the patient's all okay. And here comes the TEE probe. Secondly, it's often a CRNA or anesthetist at the top of the bed. And these are people who flow in and out. There's multiple ones. They don't specialize as many as even the anesthesiologists do. And yet it's them who has the first response and ability to recognize when this is happening. With an end-tidal CO2 drop, happens immediately. And so this is discussed with every single provider before the cases now. We use lower pressures, and we've done significant different things in case choice, and we're more careful when we do these cases. But that's all I have to say about this.
Thank you. Just wondering, I mean, anecdotally, it sounds like it's a more prevalent complication than 0.4%. Do you think, in your experience, that number is correct, or what is your gut feeling?
Yeah, I mean, when you look at the paper, that part of the discussion in this, it says in a balanced approach that, hey, the fact is, in some series, hysterectomy and others, with the most capable technology, TEE and other invasive monitoring, that perhaps this CO2 embolism happens near 100% of the time. The problem is with that argument that this is all very subclinical. Subclinically, sure, it happens probably all the time, very frequently, but you don't have cardiac arrest, or even more so, surgery that's stopped, that's taken up later, increased cost of care, increased complications. This is so I'm sure if, secondly, just given that this was all by observation and by surgeon, prodding of no reportable databases, but enthusiastic surgeons around the world, that surely this happened to many of them, with an anesthesiologist back there going, ooh, what just happened? it's coming back up, never mind. And so there surely was, it may be more, non-subclinical with real clinical ones, because of the fact that they're short-lived and they're often not perfectly diagnosed because the TEE probe isn't around in every operating room. Surely that's probably underestimated. I guess with that, though, I'm reassured by the fact in this small cohort that people didn't die, and that by appropriate thought going into these cases, I think you can prevent this for the most part, and or make people aware and make them less clinically impactful.
Another question, and everyone in the audience, please feel free to ask questions too. But another question that I have is there a benefit of having a pressure difference between the abdominal dissection and the transanal dissection? And following to that, what is the order of dissection that you prefer, and is it a 1 or 2 team?
I think we were going through as far as team approach, I think we were going through an evolution of this still, as far as there's one huge other component that I wanted to mention of it before, and that is resident training. We may say, where the tumor is, where the pelvis is, how wide, how narrow, how obese, how this and that, all these factors that make us consider these things. But actually, this is a core component for trainees that the ASCRS, I think the ASBCRS, I think it's 50 pelvic dissections. And so choosing which one to do by what fellow is perhaps there and what they need to be exposed to also plays into this. Secondly, we were already evolving. Then the pandemic came, courses shut down. We really kind of showed a lot of the benefits of synchronous surgery when we would perform courses, but in real life, we were very often much like every other place in the United States, at least, that may have a personnel problem with 4 surgeons at a time. In the cases that I've done this year, so far, they've often been in extreme cases where by myself and a fellow. And lastly, there's huge learning opportunities to do it all with just one fellow. As in when you go from above and you're doing a robotic, a lap, or any case, that only when the trainee begins to experience what is so difficult about exposing the obese male pelvis, do they get to recognize some of the real benefits of then going below and just doing the last little part from a transanal approach. And so there's just so much variation in this, and while still trying to standardize this and making rectal cancer surgery as tough as possible. What other components of the questioning? Because I got order and synchronicity and what else?
Difference in pressure.
Yeah, the pressure part, is another thing which I think can be so variable. It depends at the physiology of the effects from below and above, what exposure there is. Is there a vacuum, a suction effect with any fluid in the pelvis? Is the morbid obesity? And I think it varies and changes whether there's communication up in above and below. And those things are only, I think accounted for with experience and having 2 really experienced people above and below. And in the last year, just COVID and personnel wise, we haven't been doing much synchronous surgery. I can say that for sure.
Thank you. Anyone from the audience, any comments about this paper? All right. Well, in the interest of time, then let's move on to the summary from our poll.
All right, we're gonna present these, sharing results. So we started with the question: if you're the patient and you had to have an ultra low resection, which of these methods would be preferential? Would you choose for your operation? So we have here, a pretty small number of people that are going to go straight to open, or certainly a winning vote for robotic surgery. Somewhere in the middle, TME is up at 6 votes out of our 39 responses, and laparoscopic a little more. We're going to compare that with question number 2. You can see we have an immediate increase in the number of people that would like an open operation done for their partners. Slight decrease in the robotic and laparoscopic. Actually, laparoscopic is still pretty well represented. Sorry, I did not get that question.
Oh, okay. I was wondering if I was muted because, going back to Vlad's first comment, where then was Dr. Gallendyke said, it's why we hand sew, is that, my option isn't on here anymore. Often then, a hybrid of these approaches, using the robotic surgery to get as low as you can, but still in many of these, then combining the best features of both and probably without gas can go to the bottom and do the last part, the distal margin under direct vision and reconstruction from a transperineal approach as well. So I think you've seen Antonino Spinelli talk a lot about this. He's even got a new name for it, and doing kind of combining the best features of TME without some of the concerning components, the gas insufflation the entire time, and prolonged stretching of the anal canal. And so a combination of both. That's why I couldn't put in the vote for TME all the way.
Yeah.
Bumped up a little bit.
All right, so that's our results.
Yeah, I think that's quite interesting because if I think what I would want for myself, the quality of life factor is much more significant than the oncological outcome. But if it is for, say, my wife, I'm a lot more egocentric about making sure that she lives for longer as opposed to whether she enjoys that life or not. Now, before we move on to the grilling Dr. Monson, I'd just like to warm up and ask him about the TME registry. And my question specifically is in relation to mechanics of registry reporting. So CO2 embolisms were not a traditionally recorded complication. And so how does one actually start recording that in a registry? Like at what point if there's an audit cycle, or when does one get a tick box to tick the CO2 embolism happened?
Yeah, I think that's a really interesting question. And, one of the, as a co-author on that paper, one of the amusing things about it was that, I recognized that from a science perspective, it's terrible. It has massive deficiencies and all of the problems. And, Susan adores registry studies, and in particular adores ones that are completely voluntary and subject to the most massive amount of bias that you could imagine. Hence, of course, the need for an editorial, because a paper like that is something of a shroud-waving affair to, wave warnings to people. And it should not be overstated in any way, shape, or form. But on the other hand, as Matt pointed out, almost nobody had seen clinically catastrophic gas emboli occurring outside of liver surgery, which is, obviously a recognized entity, etc. So it served one purpose, which is really to raise the issue and say, we're just putting our hand up to say, is this an issue or is it not? Now, as of course it came in the background of lots of other things with TME, which, internationally we tried to make sure was introduced in a rational way, and we failed. I think we failed such that there's still so many unknowns about it that at least some groups have decided to, place a moratorium on it. Registries, I think, are useful, but they're only as good as the data that you get. And, one of the differences is between Europe and the United States. The United States surgeons in general are very antagonistic towards submitting their data to a sort of a collaborative A collaborative is a step away from some form of commune, which is 2 steps away from socialism, which is essentially communism. And so that's the problem. Whereas in Europe, people will say, well, what's the problem? Yeah, of course you can have my data because it's important for the greater good. And it's just a DNA hardwired issue, etc. People are different in the way they view these things.
I thank you. I think this is a perfect segue of what I wanted to discuss with you. And I guess it doesn't take long to appreciate how well-traveled Dr. Monson is. You just have to look at the number of letters after his name and the combination of different royal and non-royal fellowships. But I'd like to take this opportunity to compare colorectal practice in North America compared to Europe and the UK. So being in Australia, for example, myself, there's a combination of public and private medical industry. And so most of the surgeons have a percentage of private work, which is university hospitals, and then their public work, university hospitals, and their private patients that come and see them. And when my exposure in America was that patients tend to come and present to a clinic. They don't really care what surgeon necessarily they see, but they trust or put their faith in the institution. And so I'd like to ask, what do you think is the difference in the colorectal patient psyche between Europe or the UK and North America?
Well, so I'd start by saying that everything you say about the USA is true somewhere. And it's equally untrue because it's a very geographically disparate country. It's the biggest, it's the smallest, it's the richest, it's the poorest, it's got everything going for it. One of the things I have said for many years is that there are 6 institutions in the United States where patients go to purely on brand alone. They really wouldn't care if there isn't a doctor there because the brand does it and they're known to everybody. They're the Mayo Clinic, the Cleveland Clinic, Memorial Sloan Kettering, MD Anderson, MGH, and Hopkins. Everyone else has a combination of brand and personal reputation. So Advent Health, for example, in Orlando has a brand awareness, but some of the doctors also have personal reputation. And that's the case for the vast majority of places. The institution you worked in the Cleveland Clinic is a unique institution, or it's at least one of a small handful where the brand does it. And you see that all the time when a doctor leaves, the Cleveland Clinic or the doctor leaves MD Anderson. They always think, all my patients will follow me, and they don't. They stay with the institution for the most part. In the UK, it's different. I would contrast, for example, the UK is a little bit, Ireland is just like Australia. It's a 50-50 public service with a very vibrant 50%, if not more, private sector. The UK is mostly NHS, but there is a strong private sector. About 12% of the population are privately insured, and most surgeons will work in the private sector. But there is one big thing that marks the patients in the UK, and that is that in common with the staff who work in the NHS, they have a passionate belief in the NHS. They know it's full of problems, and it is a national sport to complain about the NHS and waiting lists and one thing or another, but they are allowed to complain about the NHS. You are not. As a foreigner, you are not allowed to complain about it. When I worked in the NHS, one of the things that struck me powerfully, and I would, one time or another, I worked in the NHS for 20 plus years. They have a passionate belief in the value of the NHS, and they know it's terrible and all sorts of things, and it doesn't have enough money, and it doesn't have enough this, that, and the other. But they recognize that it's an enormously beneficial thing for society, and they do believe in it. Now, the individual patients they will be driven by referral patterns as human beings are everywhere. So, Mrs. Jones knows that they went to so-and-so, who's a lovely guy, because he has, he plays golf with the uncle, who, et cetera, et cetera. It's no different. They will often go to hospitals, the big hospital. They don't want to go to the small hospital. If it's something serious, they'll go to the big city. The big city in the UK is not 4.5 hours away. It's 30 minutes away. That's a big trip. In Yorkshire, for example, which most people will have heard of Yorkshire, Yorkshire from one end to the other is 150 miles. But for a patient to go where I worked, to Leeds was 70 miles. They considered you needed a passport to do that. They were not going there. No way. That was just like a different country. So now they will decide differently between a hospital 5 miles away, but they won't go that far.
That's very interesting. Now, American inpatient stays are typically notoriously expensive, and I find that understanding the quoted costs and value, value within economic studies is very complex. So how would you advise to look at economic studies within medicine from different countries, and what would be the meaningful points to take to a local environment?
I mean, my basic advice is that I would find another study to do, because cost and expenses are incredibly complex. Comparing the UK, for example, with North America is a fool's errand. The whole business model is different. The cost structure is different. The way it's measured is different. There are plenty of healthcare facilities in the United States that are not for profit, and there are many that are for profit. Their cost and charges, debate, hugely different. Most reimbursement in the United States is based on something in the region of 20 cents in the dollar. In other words, the charge is $100 and the hospital expects to get maybe $20. That's not how it works in the United Kingdom. The United Kingdom is based on a capitated budget. This hospital here gets this block budget for this financial year and is expected to deliver that amount of work based on what they did last year and what they negotiated. There is no charging going on, because everybody's salaried and it's done entirely differently. There's no charges. There is a cost, of course, but that cost is not based on profit. It's closer to, but not accurately aligned to what it actually costs to do the business. But what they amazingly managed to make sure happens is that the cost is just a little bit more than the budget they got last year. In other words, so that next year they can ask for a slightly higher budget from central government. But that's how it works in the UK. Your organization or your region gets a budget given to you for the year.
Going back to sort of the studies that we discussed and implementation of new technologies, and sort of comparing robotic surgery and TME specifically, looking at the UK and United States, do you think it's a difference in terms of funding, the environment, or something else in terms of which is going to take the lead?
Well, it's a combination of factors, but there's no question that the funding for new technology is, sorry to use the words, but it's fundamentally different. The funding comes from government. And so for robotics is a good example. So robotics, has risen to the level that it's risen to in the United States through a combination of factors: clinical benefit, marketing, profit making, et cetera, not heavily based on good, robust, randomized controlled trial evidence. But the individual hospital has free rein to just go out and buy 6 robots if that's what they want to do, if that fits with their business model. That's not going to happen in the United Kingdom, because that hospital, if it wants to buy a robot, has to justify it based on something a little more than just marketing. Because marketing is not a requirement. There's no requirement to market. You already have the patient load that you want. And so you're going to have to go through a different process. In this country, it's described as rationing of healthcare, which is a step away from death panels. It's neither. It's rationalization of limited resources. So if you want, as a Minister of Health said to me once, he said, we're simply asking if there could be some attention paid to value for what we're doing. We're not asking that it's not done or it's restricted or it's banned or anything, just some attention paid to value. And that value is addressed by people like NICE, which is the National Institute for Clinical Excellence, who takes new technologies and say, what is the evidence for this? Is the evidence that it's brilliant, it's terrible, it's somewhere in between? Should it be funded? Because they're using taxpayers' dollars, if you like.
Okay. My last question, going back to what Dr. Albert mentioned about training, and particularly training and implementation of new technology, can you contrast the training of fellows for rectal cancer in the US versus the UK?
Yeah, so over the last 30 years, I think the training in the US, in the UK has changed very dramatically. Without getting into the, when I was a kid type story, but when I was a kid, there were no restrictions on work hours, etc. And so, you're on all day, every day, yada, 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 all of that sort of stuff. And there was a very high degree of independent operating by trainees across the board. So the first thing you were taught as a resident was how to do an appendectomy so that you could do it independently without calling anyone in to help you. That was the reason. And so you learned. So there was a lot of, the UK or Irish trainees would not necessarily have done one of everything, but they would have done 50 of most things. In the United States, and these are generalizations, of course, in the United States, trainees traditionally have done one of everything, but not 20 of anything. As hours restrictions on both sides of the Atlantic kicked in, it became a problem as to how to deal with that. And so the UK moved towards identifying educationally beneficial time. So being on call at night, yes, it has some use, but educationally, not as much as being in the OR tomorrow being trained by Matt Albert. So they stopped that sort of stuff because they had to. But they had to because they got down way below 80 hours. And that not because they wanted to, but because they had no choice. And so it restricted people and it focused people on true education, the development of educational contracts. You spend 6 months with Dr. Gallendyke and working with her. You signed and she signed what was expected in that 6 months. I will get to do this, I will get to do that, because these people now had restricted time available to them. It balanced out a little bit better, but what has happened, as has happened in the United States, is that the patient exposure time has plummeted. And basically, it's lost at least a year in terms of the patient exposure time. So the same problems are faced, but there's still greater levels of depth of exposure, but not nearly as much as it was as a consequence of the working hours restriction. And it'll be really interesting to see what happens as Brexit kicks in and whether they will ramp them up. I don't think they will, because of course the restrictions were not brought about by the medical profession. It was by other professions, pilots and truck drivers and things like that.
Okay, well, thank you very much. I'm sorry to keep you a bit over time. I personally found it all very informative, and I hope and I know that our audience has as well. I'd like to again thank Advent Health, the whole colorectal unit, for hosting us and participating with such a useful and interesting discussion. And I'd like to invite all our guests to come next month, where we will go to Washington University, St. Louis, to discuss hereditary colorectal cancer.
Thank you, guys.
Thank you very much.
Thanks for the team. Have a good evening.
Thank you.
Have a good night.